If you take your blood pressure medication with your morning coffee, stop what you are doing and stay right here. If you take your water pill in the afternoon or evening, same thing. And if you have ever missed a dose and doubled up the next time to compensate, what is about to be covered is something you needed to hear before you did that. This is the conversation your pharmacist should have had with you the day you filled that prescription. The conversation that almost never happens in a 15-minute appointment. The conversation about timing. Because when it comes to blood pressure medication, when you take it is not a minor detail. In some cases, it is the difference between the medication working the way it was designed to work and the medication creating a dangerous gap in protection that leaves your heart, your kidneys, and your brain exposed at exactly the moment they are most vulnerable. There is one timing mistake seen consistently, week after week, among patients managing blood pressure. Most physicians never address it, most pharmacists never raise it at the counter, and most patients have no idea it is happening because nobody told them what to watch for. 5 mistakes. 5 windows where the timing of a blood pressure medication either cuts its effectiveness significantly or creates a genuine cardiovascular risk that was never necessary. And at the end, 5 specific questions to bring to the next appointment, because the physician who knows the full medical history is the right person to apply this information to a specific situation. What follows is the framework they need to have that conversation properly. Stay through mistake number 3. It is the one that surprises people the most, and it is the one with the most preventable consequences. Before getting into the mistakes, one thing needs to be said clearly. Blood pressure medication saves lives. The evidence base for treating hypertension is among the strongest in all of cardiovascular medicine. There is no ambiguity about whether these medications work. The ambiguity, and the risk, lies in the details around how they are used. Not whether to take them, when to take them, what to take them with, what to avoid around them, and what to do when a dose is missed. Those details did not make it into the appointment. They need to be addressed now. The first mistake involves one of the most widely prescribed classes of blood pressure medications on the market, and a dosing convention that has been repeated for decades without adequate questioning. ACE inhibitors and ARBs. Medications including lisinopril, ramipril, enalapril, losartan, valsartan, and olmesartan. These are among the most commonly prescribed drugs in the world, taken by tens of millions of people every day. And for decades, the standard instruction attached to nearly every prescription has been the same: take once daily in the morning. That instruction was a convention. It was practical. It was easy to remember. It was aligned with the general principle of daytime medication management. But it was not necessarily evidence-based, and more recent research has raised a question that deserves to be asked by every person on one of these medications. The human cardiovascular system follows a circadian rhythm. Blood pressure is not constant across the 24-hour cycle. It is lowest during deep sleep, when the parasympathetic nervous system is dominant, and the heart is working at its lowest demand. Then, in the early morning hours, as the body begins transitioning toward waking, the sympathetic nervous system activates. Cortisol rises, heart rate increases, vascular resistance climbs, blood pressure surges. This surge is not a minor fluctuation. It is a significant, reproducible physiological event that occurs every morning in virtually every human being. And it carries a documented consequence. The early morning hours, roughly from 4 in the morning to noon, represent the window of highest cardiovascular risk across multiple studies. This is when heart attacks are most likely to occur, when strokes are most likely to begin, when sudden cardiac death peaks. A blood pressure medication taken the previous night at bedtime will still be active and effective during that vulnerable early morning surge. It covers the window of highest risk. A blood pressure medication taken in the morning, after the surge has already begun, may be absorbed and begin reaching therapeutic levels precisely as the peak risk window is already passing. The medication peaks when the risk is declining and reaches its lowest level of the day as the next morning's surge approaches. Research examining bedtime versus morning dosing of antihypertensive medications has shown meaningful differences in outcomes. Lower rates of cardiovascular events in patients who took their medication at bedtime compared to those who took the same medication in the morning. This is not a fringe finding. It has been replicated across multiple study populations. The honest position is that the science continues to evolve, and the optimal timing depends on the specific medication class and the individual patient's blood pressure pattern. Some patients have elevated nighttime blood pressure, some have a blunted overnight dip, some have a pronounced morning surge, and some have a pattern that is effectively flat throughout the day. The right timing answer is individualized. But here is what matters. Most patients have never been asked the question. Most physicians have not revisited the default morning instruction, even as the evidence base around it has expanded. The question worth bringing to the next appointment is direct. Given my specific blood pressure pattern and the medication I am on, should I be taking this at bedtime rather than in the morning? If the answer comes with a thoughtful, personalized explanation, that is a good sign. If the prescribing physician has genuinely never considered it, that is equally informative. The second mistake is one that has been sitting in the breakfast routine of patients on a specific class of blood pressure medications, and the consequences range from uncomfortable to genuinely dangerous. Grapefruit and grapefruit juice. Grapefruit contains a family of chemical compounds called furanocoumarins. These compounds do something highly specific inside the digestive system. They block an enzyme called CYP3A4, which is embedded in the wall of the small intestine and in the liver, and whose primary job is to metabolize a wide range of medications as they are absorbed into the bloodstream. CYP3A4 is essentially the body's drug processing regulator, breaking down medications at a controlled rate so that blood levels remain in the therapeutic range, not too low to be effective and not too high to be dangerous. When furanocoumarins from grapefruit block this enzyme, the processing regulation is disrupted. Medications that would normally be broken down during absorption instead pass into the bloodstream largely intact. Blood levels of the drug rise substantially, sometimes dramatically, above the intended therapeutic range. For blood pressure medications, specifically calcium channel blockers including felodipine, nifedipine, and amlodipine, this is not a theoretical concern. The interaction is well documented and clinically significant. When a calcium channel blocker reaches blood levels significantly above the therapeutic range, the drop in blood pressure it produces is correspondingly exaggerated. Blood pressure falls further and faster than intended. The consequences include dizziness, profound lightheadedness, fainting, and in patients with underlying cardiac rhythm abnormalities, dangerous arrhythmias triggered by the sudden hemodynamic shift. What makes this interaction particularly difficult to recognize is a feature of grapefruit's effect that most people are never told. The enzyme-blocking compounds in grapefruit are not cleared from the digestive system quickly. The effect of consuming grapefruit or grapefruit juice can persist for up to 24 hours, in some individuals up to 72 hours, after the grapefruit was consumed. This means the grapefruit juice consumed with Tuesday evening's dinner can still be affecting the way Wednesday morning's blood pressure medication is absorbed. The connection is not obvious. The timing between the food and the medication reaction is separated by enough hours that most patients never make the association. They experience dizziness or a dramatic drop in blood pressure and attribute it to the medication itself, or to standing up too quickly, or to any number of other explanations, while the actual mechanism goes unidentified. Anyone taking a calcium channel blocker for blood pressure or any other cardiovascular indication should ask the prescribing pharmacist directly, is grapefruit an interaction concern with this specific medication? Not calcium channel blockers as a class, but this specific drug at this specific dose. The answer matters, and it needs to be asked explicitly rather than assumed. Now, mistake number 3. This is the one that consistently surprises people the most, not because it involves a complex drug interaction or an obscure food, but because it involves something as simple as what time of day a pill is swallowed. And the downstream consequence of getting it wrong is one of the most preventable serious injuries in older adults. Diuretics, water pills, medications including hydrochlorothiazide, furosemide, chlorthalidone, and spironolactone. These medications are prescribed as a core component of blood pressure management for millions of people. They work by prompting the kidneys to excrete more sodium and water, reducing the total fluid volume in the circulation, and thereby lowering blood pressure. The mechanism is straightforward. The timing implication of that mechanism is something that many patients are never told. When a diuretic is taken in the morning, its peak effect, the period of highest urinary output, occurs during the day. The person is awake, mobile, aware of the need to urinate, and able to respond to it safely and conveniently. By evening, the peak effect has passed. Overnight, urine production returns to baseline, and sleep is not significantly disrupted. When a diuretic is taken in the late afternoon or evening, the peak effect occurs at night. Urinary frequency peaks between midnight and 4 in the morning. The person wakes repeatedly from sleep. This pattern is accepted by many patients as simply what the medication does, as an unavoidable side effect to be managed. It is not. It is a direct and entirely preventable consequence of incorrect dosing timing. The disrupted sleep itself is a significant problem. Chronic sleep fragmentation affects blood pressure regulation, increases cortisol levels, reduces cardiovascular recovery during the overnight hours, and independently increases cardiovascular risk over time. But the more immediately dangerous consequence is what happens each time an older adult with a diuretic-driven urge to urinate gets out of bed in the middle of the night, in low light or darkness, possibly disoriented from disrupted sleep, with blood pressure that may drop significantly upon standing, a phenomenon called orthostatic hypotension, which is common in older adults and exacerbated by diuretic use. The risk of a fall during each of those nocturnal trips is real and measurable. Falls in adults over 70 are not minor events. Hip fractures resulting from falls in this age group carry a one-year mortality rate ranging from 20 to 30%. That is not a statistic about a rare complication. It is a documented outcome affecting a significant proportion of older adults who sustain a hip fracture. And the causal chain from incorrect diuretic timing to nighttime fall to hip fracture to mortality is mechanistically straightforward and entirely preventable. The rule is simple and should be communicated to every patient on a diuretic at the time of prescription. Take the diuretic in the morning, ideally before 10 in the morning, so that peak urinary output occurs during waking hours. If the prescription is for a twice-daily diuretic, the second dose should be taken no later than 2 in the afternoon. After 2 in the afternoon, diuretic timing creates nighttime risk. That boundary is not arbitrary. It is based on the drug's duration of action and the goal of keeping peak effect within the waking day. If the current routine involves an afternoon or evening diuretic dose, that is a conversation to have with the prescribing physician at the very next opportunity. Not because the medication needs to change, but because when it is taken, absolutely needs to. Mistake number 4 involves a combination that is present in the morning routines of a very large percentage of people on a specific class of blood pressure medications. And it is a combination that creates a direct physiological conflict most patients are completely unaware of. Beta blockers and caffeine. Beta blockers, including metoprolol, atenolol, carvedilol, bisoprolol, and propranolol, work through a specific mechanism. They block the beta-adrenergic receptors in the heart and blood vessels that respond to adrenaline and the sympathetic nervous system. By blocking those receptors, they reduce heart rate, reduce the force of cardiac contractions, and lower the blood pressure response to sympathetic stimulation. Caffeine works through an opposing mechanism. It activates the sympathetic nervous system, increases heart rate, temporarily elevates blood pressure, and stimulates the exact adrenergic pathways that the beta blocker is designed to block. Taking a beta blocker and consuming a significant amount of caffeine within the same 30 to 60-minute window creates a pharmacological conflict. The medication is trying to suppress sympathetic activation. The caffeine is simultaneously trying to produce it. In most patients, the medication's effect predominates. But in patients with a history of cardiac arrhythmias, the caffeine-driven sympathetic activation during its peak absorption window, roughly 30 to 60 minutes after ingestion, can produce palpitations, irregular heartbeats, or an exacerbation of an existing arrhythmia despite the presence of the beta blocker. There is an additional layer to this interaction that involves individual genetics. Metoprolol, one of the most widely prescribed beta blockers, is metabolized by an enzyme called CYP2D6. A significant subset of the population carries genetic variants that make this enzyme slower than average. In these individuals, classified as poor metabolizers, metoprolol reaches higher blood levels and stays active longer than in average metabolizers. In this population, the interaction between caffeine and metoprolol is potentially more significant because the medication itself is already at higher than expected concentrations. The practical guidance is not complicated. If a beta blocker is part of the daily medication regimen, wait at least 30 to 45 minutes between taking the medication and consuming coffee or any other significant source of caffeine. Allow the medication to begin its absorption process before introducing the sympathetic stimulant that works against it. For patients with a documented history of cardiac arrhythmia, this interval is worth taking seriously rather than treating as optional. This is a small timing adjustment. For a subset of patients, it may be a clinically important one. The 5th mistake is the most frequently encountered, and its danger level varies enormously depending entirely on which medication is involved, which is precisely what makes it dangerous, because patients who manage it safely with one medication often apply the same approach to a different medication where it carries significantly more risk. Missing a dose and doubling up. This is an almost universal experience for anyone managing a daily medication regimen. A dose is missed in the morning, it is remembered at noon, or at 3 in the afternoon, or at dinner. The intuitive response, particularly for someone who understands that consistent blood pressure control is important, is to compensate. Take 2 doses, restore the coverage, get back on schedule. For some blood pressure medications, this approach carries relatively limited risk. For others, it creates a serious problem. Calcium channel blockers taken in double doses can produce a rapid, significant drop in blood pressure. Blood pressure falls faster and further than the cardiovascular system can compensate for through its normal regulatory mechanisms. The result is dizziness, profound lightheadedness, and a high probability of syncope, a sudden loss of consciousness due to inadequate blood flow to the brain. In an older adult, syncope is a fall event. A fall event is a fracture risk. The sequence from a double dose to a hospitalization is not a remote possibility. It is a documented, recurring clinical pattern. Certain ARBs and beta blockers carry similar risks when doubled. The specific risk profile depends on the drug's half-life, its mechanism of action, and the individual patient's baseline blood pressure, vascular tone, and age-related cardiovascular reserve. The standard guidance for a missed dose is this. If the missed dose is remembered on the same day and it is not yet close to the time of the next scheduled dose, take it as soon as it is remembered. If it is close to the time of the next dose, skip the missed dose entirely and resume the normal schedule. Never double up without first asking a physician or pharmacist whether doubling is safe for that specific medication. The answer is medication-specific. It cannot be generalized. There is a second version of this mistake that is quieter and more sustained, and therefore in some ways more consequential. Patients who are prescribed twice-daily medications and find the schedule difficult to maintain begin taking them once daily. The decision is practical. 1 dose is easier to remember than 2. The blood pressure numbers, checked occasionally at home or at a routine appointment, appear acceptable. The physician, seeing numbers that are within a manageable range, does not investigate further. The medication dose is never adjusted to account for the once-daily administration, and the cardiovascular protection the twice-daily regimen was designed to provide across the full 24-hour cycle is incomplete during the unmedicated hours. This situation persists, sometimes for years, without anyone identifying it, because the patient does not volunteer the change and the physician does not ask. The blood pressure numbers look controlled enough that the question never arises. But controlled enough is not the same as protected. If the current regimen involves a twice-daily medication being taken once daily for convenience, that fact needs to be disclosed to the prescribing physician at the next appointment. Not because it reflects a failure, but because the physician needs accurate information about what is actually being taken in order to manage cardiovascular risk accurately. Now the questions, because everything covered here is background. The actual value of this information depends on what happens in the next medical appointment, and that depends on asking the right questions with enough specificity that the answers are genuinely personalized rather than generic. 5 questions worth bringing to the next appointment with a prescribing physician or pharmacist. The first, should this specific medication be taken in the morning or at bedtime, given individual blood pressure patterns? Not what the convention says, what the evidence and the individual pattern together suggest. The second, are there any foods, drinks, supplements, or other medications that interact with this specific drug around the time it is taken? Grapefruit is the most documented example for calcium channel blockers, but it is not the only interaction worth asking about explicitly. The third, what is the correct protocol if a dose is missed? What to do varies by medication. This question needs a specific answer for each medication in the regimen, not a general rule applied across all of them. The fourth, is there a pattern to when blood pressure tends to be highest throughout the day? Home blood pressure monitoring, done consistently at the same times each day for a week, and the results brought to the appointment, gives the physician the data needed to answer this question meaningfully. Without that data, the answer is a guess. The fifth, are there timing interactions between this blood pressure medication and any of the other medications currently being taken? Polypharmacy, managing multiple medications simultaneously, is extraordinarily common in adults over 60. The timing interactions between medications are frequently more clinically significant than the interactions between any single medication and a food or drink. Those 5 questions, asked directly and answered with the full medical history available, will accomplish more for long-term cardiovascular protection than any general information provided without access to an individual's specific history, specific medications, and specific physiological patterns. One final thing needs to be stated, and it bears repeating because nothing in what has been covered here should be interpreted as a reason to change, skip, or stop a blood pressure medication without physician guidance. Blood pressure medication works. The evidence is unambiguous. Treating hypertension prevents heart attacks. It prevents strokes. It prevents kidney failure. It preserves cognitive function. The question is never whether to take it. The question is how to take it in a way that maximizes its protection and minimizes the risks created by timing errors that are entirely preventable. The 15-minute appointment did not have room for all of this. Most appointments never do. But the information exists, the questions can be asked, and the conversation can happen with the right person at the right time. The medication is already doing part of its job. The timing is the part that determines how much of the rest of that job actually gets done. And in the early morning hours, when the blood pressure surge arrives and the cardiovascular system is at its most vulnerable, what was taken the night before, what was avoided around the dose, what was not doubled up on after a missed morning, will determine how protected the heart actually is during the window when protection matters most. That window arrives every morning. The question is whether the medication is still working when it does.